Good evening, everybody, and welcome to our webinar tonight. My name is Jenny Pearson, and I'm an Education Officer for the Primary Health Network. Before we go any further, I'd just like to acknowledge the traditional custodians of the land that we're all meeting on tonight and pay respect to elders past, present, and emerging. Tonight, our webinar is The Hidden Disorder in Childhood, Speech, Language, and Communication Difficulties in Children. We have two subject matter experts, Dr. Mary Klassen. She's an experienced speech pathology researcher and clinician and is a current academic staff member in the Curtin University School of Allied Health. Mary's research focuses on improving quality of life for people with communication and feeding difficulties. We also have Kate Headley. She's worked extensively as a speech pathologist in the disability sector, direct therapeutic services, clinical supervision, community capacity building projects, and student education. We also have Sandra Fitzgerald, who is a clinical editor with the Health Pathways program with the Primary Health Network. Don't forget that you can type in questions if you need to tonight, and if you could all please fill in the evaluation at the end of the session. This event is accredited, so if you would like your points and a certificate of attendance, please fill in the evaluation at the end. All right, we might hand over to Kate and Mary.
Hi, everybody. Thank you. I'm Kate Headley, and you'll shortly meet Mary on the screen. Thank you to the PHN. Mary and I are really thrilled about the opportunity to collaborate with GPs and other primary health providers in regards to communication disorders in children. So tonight we have the opportunity to view the recently reviewed and live version of the Speech, Language and Communication Difficulties in Children Health Pathway. But in conjunction with that, Mary and I really hope that we can share some information with you all that will build your confidence in identifying indicators of concern, and I guess then feeling confident to work with families to connect children with speech pathology services. So our screen print here was when the pathway was still under review, but it's now gone live in the last couple of days, and Sandra will be talking to that later on tonight. I just wanted to flag at this point, though, that there is some specific areas of information in the pathway that we've included because of how relevant and important they are. And one of those is the introduction of developmental language disorder. And we're going to talk about that tonight and come back to that in a fair bit of detail, because it really is one of the most prevalent neurodevelopmental disorders in childhood, yet it's very under-recognised. So it's a great opportunity for us as a group of primary health providers to be learning more about that. We also flag in the pathway some specific area information about how complex trauma experienced in childhood increases the risks of children having communication disorders, and we'll discuss more of that tonight as we go. So as we get started, I think it's just a really important starting place is to have some shared terminology. I imagine all of you, like me, working in multidisciplinary teams, have heard people use terms to mean slightly different things. So speech pathology as a profession work with people across the lifespan who have difficulties with communication and swallowing. But our focus tonight, as it aligns with the health pathway, is specifically on communication skills in children. So effective communication, so communication here is kind of the umbrella term, and effective communication results from a range of contributing skill areas. So within the health pathway, we talk about language. And that term language is a really abstract concept for parents and carers to visualize, because language is not about how a person says words, but rather how they're able to formulate in their mind what they want to say, and critically, how they understand and comprehend what other people say to them. And language skills are directly related to our ability to participate in activities across our day, develop our social emotional skills, build relationships, and learn. And specifically, research highlights the critical relationship between early developing language skills and subsequent development of learning to read and write. Language is very different to speech. So, speech in the health pathway is specifically referring to how a child's talking sounds, so their pronunciation of words, and importantly, whether people can understand the child's talking. Hearing is obviously a really critical component for developing speech, but also for developing language skills. Fluency in the health pathway is referring to whether a child is talking with a stutter. So that might be where they're repeating sounds, words, phrases. They might be having long pauses, or some people use the term stammering when they talk. Voice is a term used in the pathway, and it's discussed in the pathway in referring to whether children are able to use their voices in the ways that they want and need to. So, for example, if a child is experiencing pain using their voice, if they can't get enough volume to be heard in their different activities, if they're frequently losing their voice, or if they had a vocal quality, so if their voice sounded different to a way that they're comfortable with, then they're all things that will be impacting the effectiveness of their communication. And finally, the pathway uses the term pragmatics to describe the way that children use language for social purposes. That is, using language to interact, participate in conversations with different people in different environments, to use language for play, and to build relationships. So, in speech pathology research and literature, we'll often see the terminology or acronym SLCN, standing for speech, language, and communication needs. And that's used again as an umbrella term to refer to all people who are having communication difficulties relating to speech, or language, or voice, or fluency, or pragmatic impairments. Now, we haven't used that term on the previous slide because that's not terminology reflected in the health pathway. But what is really important for us to clarify here tonight is that some speech language communication needs might be short term, and some can be addressed through effective early intervention. But a bit of a misdemeanor, or something that's not really known in the community, is that many speech language communication needs can be more permanent and can remain throughout a person's life. Communication disability really is a hidden disability in childhood. And in fact, when you talk to adults throughout their lifetime, people with communication disability are often mislabeled. So, a child who might have limited language might be judged as not very bright or just quiet and shy. Conversely, an adolescent who might have very weak comprehension skills might be judged as a troublemaker or uncooperative. Language disorders also often co-occur in the context of adverse childhood experiences and complex trauma. And subsequently, The recognition of them and diagnosis of them can be lost in a child's presentation, which at the time is often focused perhaps on their psychological well-being and their behavioural support needs. And Mary and I really wanted to flag that some types of communication difficulties, such as a child's difficulty saying speech sounds, or if their speech is difficult to understand, or stuttering behaviours, might be observable in a consultation with a family. But tonight, we really want to flag and focus on the challenge of early identification of language disorders. That is, how a child is understanding what others say to them and how they can formulate what they want to say. This is an extremely hidden disorder, and it has lifelong impacts if left undetected. So early identification of difficulties with speech, language, and communication skills is vital at an individual's level, but also for family functioning, and then more broadly for the health of the community within which the family live. Language disorders impact the individual across educational, health, and social outcomes. And then that goes on to contribute to the economic and social outcomes of their community. And the research shows us that this then contributes to cumulative vulnerability in communities through the clustering of ACEs, those adverse childhood experiences, and psychosocial risk factors. Specifically, early identification of language disorder helps us to change the subsequent interplay between language disorder, literacy and learning difficulties, mental health disorders, and behavioural support needs. So if we have a really quick look at some of those key areas, and I am really mindful that we're looking at a very brief snapshot in the time that we have tonight. But in regards to emotional, behavioural, and mental well-being, the research shows a clear association between poor oral and written language skills and poor mental health and behaviour outcomes. And a 2019 review concluded that over 70% of children who experience emotional and/or behavioural issues also demonstrate language impairment. Children and adolescents with oral language disorder are at considerably increased risk of both internalising and externalising behaviours and subsequent disorders, including anxiety and depression, conduct disorders, attention difficulties, anger, and aggression. And this relationship stems from language skills and psychosocial and emotional development being strongly interrelated from early childhood. Strong oral language skills have been shown to play a central role in a child's identity formation, their sense of self, their self-expression, and the development of their emotional awareness that then informs their family and peer relationships. In regards to literacy and subsequently learning, there is a wealth of research that demonstrates that strong oral language skills are crucial for reading success. Consequently, language disorders that contribute to literacy and learning difficulties lead us to the evidence around the poor psychosocial, emotional, academic, and vocational outcomes associated with reading difficulties. So more broadly, research has confirmed that strong oral and written language skills in childhood are the cornerstone for successful development across domains of adulthood. So, Mary and I understand that occasionally families might ask you, as their GP or their health provider, directly about a child's speech or language development. And we hope that the reviewed health pathway document provides you with those guidelines, resources, and pathways to respond to that child and family. However, we're also really mindful that in the context of episodic care, many families may present with an unrelated issue, and you might happen to notice some indicators of concern for speech, language, and communication needs. And we're hoping tonight that we can highlight the opportunities for all primary health providers to start a conversation with families around a child's communication skills and build a service sector where all adults who come in contact with a child can play a role in identifying children and link who have speech, language, and communication difficulties and link them with helpful services. So I'm just going to pass over to Mary, who's going to start to introduce a hypothetical family that we might have episodes of care with.
Perfect. Thanks, Kate. So let me introduce you to a family, not unlike many of those that you see in your practices. So we have Mum, Chloe, Dad, Sean, and we then have their son, Tommy, who's currently aged 3.5. And Chloe makes an appointment to see you. And her reason is she's looking for some support with what she describes as high levels of stress. She's experiencing low mood and insomnia. So she comes along to the appointment with her 3.5-year-old son, Tommy, who you've previously treated for a middle ear infection. Now, while Chloe's made the appointment for herself, you can't help noticing Tommy's communication. And this is what Kate was referring to. A family may not approach you directly to discuss a child's speech, language, and communication, but you may happen upon some observations. So during the appointment, it's quite hard to talk with Chloe because Tommy's very busy. He's not actually playing with the toys. He's just kind of throwing them around the room. And so that's one of the first indicators of concern that you notice. He seems to have very little interest in symbolic play. You notice that he doesn't really seem to be doing what Chloe asks him to do, and that Chloe seems frustrated about this, understandably. And you might think to yourself, I wonder why he's not doing as Chloe asks him. Is it as simple as behaviour, or is there an underlying language difficulty? Perhaps he hasn't understood what she's asked him to do, or perhaps there's something he's wanting and he's not able to express those needs. And very often we find that a child's speech and language or child's language difficulties can be reflected in their behaviour. You notice that Tommy's communicating with his mum by pointing, and the only word you hear is mum. Now that's perhaps not surprising, given that Tommy's in an unusual setting with a stranger, so he's, possibly not going to be showing his best communication. But we do expect more than single words at 3.5. We'd really be expecting him to be chatting away using sentences of kind of 3 to 4 words and holding a conversation. And as well as this, you kind of notice the relationship between Tommy and Chloe. You wonder if the mum's low mood and her insomnia could be driving some stress in the household. Todd, I might need you to change a slide for me, please. Oh, here we go. So let's step aside for a minute and let's talk about late talkers. So in young children who are late to talk or late talkers, it can be really challenging for us to know which one will continue to have impaired language at, say, 4, around school entry time, and which ones will continue to have impaired language, and which ones were just a bit late to get started and who'll catch up by school entry time. Some of the risk factors that have been identified for ongoing language difficulties are a history of hearing loss or ear infections, a family history of speech, language or literacy difficulties, delays that are evident in both expressive and receptive language, so expressive language and comprehension, delayed onset of babbling, and using relatively few verbs compared to other children. On the other hand, some factors that are shown to be protective are intelligence, a child's receptive language or comprehension, the range of vocabulary that they use. So as well as using nouns or naming words, are they also able to use some verbs, some describing words, yummy, yucky, those kind of words, but also their learning experience or learning environment at home. And it's important at this stage to kind of highlight both sides. There are some children who have language difficulties or delayed language at 2 who go on to be typical at 4. But conversely, there are a group of children who are late talkers, who have good language skills at 2, who go on to have language difficulties at 4. So not everyone who is a good talker at 2 will continue to be a good talker. So we need to keep our eye out for that as well. And with the current healthcare system, it can be really difficult for us to know which children to refer, because we want to refer the right ones, but we don't want to overload the system. So it's important to keep those risk and protective factors in mind. Okay, Todd, I need you again. All right, so let's go back to our family here. So once you've addressed Chloe's concerns, you might request that Chloe makes another appointment for Tommy so that you can address or discuss his communication skills. It might be that you have time within your day to extend Chloe's appointment, but we recognise that very often this simply just isn't the case. So you might ask Chloe to make another appointment. And just a reminder here that it can be really challenging for parents to navigate the healthcare system, and that without some direction, there's a significant risk that children like Tommy are going to be disadvantaged by not receiving evidence-based intervention. So, a follow-up appointment. At this time, and when we see the pathway later, you're going to see that much of this comes from the new referral pathway. So we're going to check in if Chloe or the rest of the family have concerns about Tommy's speech, language and communication development. It's also really important right now that we make sure that the communication that you've witnessed or you've observed is representative of his everyday communication. And it's also a good time to ask if there's a family history of speech, language and or learning difficulties. When you're assessing Tommy, you'll look at his general health, but you'll specifically look at his ear health and middle ear function. You'll look at his communication and symbolic play skills and compare these to expected milestones. And of course, check his global development across all the domains. perhaps the concern is for something broader than his language. So what might you do? Well, you're going to treat and refer as needed. So you may refer him for a hearing test. And here, from our experience, families are not always good at knowing whether a child has good hearing or not. So often a family say to us, oh, yes, his hearing's great. I just rattle a lolly paper and he comes running. So parents are not always good at recognising a mild hearing loss. If there's ongoing issues with his ears, you might consider ENT referral. But we really suggest that you discuss your concerns and support a referral to speech pathology. And there's information about how to do this in the referral pathway. As I said before, there is a significant risk that if we don't discuss this and support the family, that children like Tommy will be disadvantaged because they'll miss out on receiving evidence-based intervention. Thank you. So let's move on to the next time that you see the family. You later see them when you work with Chloe for prenatal care. So Tommy's now 5 and Chloe tells you that he goes to preschool 3 days a week. During your appointment with Chloe, you start a conversation after you notice some bruising. And she discloses that her partner has some trouble with his anger, but it's not a regular thing and she doesn't feel unsafe. However, this is a warning sign for you, as we know that the incidence of speech and language difficulties is much higher in children who experience abuse and or neglect. So you're building up a little bit of a picture here about Tommy. All right, let's look at the your consultation now. Oops. Right. So you notice that Tommy often answers his mum with short phrases such as nah, no way, go away. And he talks in a really loud voice. Chloe reports to you that sometimes he yells so much that he loses his voice. So on that point, some of the things that we would observe and be curious about are: we might have noted the unusually high use of negative type language. And again, we just need to check if it's representative or if it's a kind of bad day and he's tired or you know, whatever. We want to make sure that it's representative, not a one-off. Might also wonder why he yells so much, because it seems to be impacting his vocal health. Tommy seems pretty happy to interact with you, but he doesn't really hold a conversation. And you find yourself having to ask lots of questions and really carry the load to keep the conversation going. But we know that at 5 years of age, a child should be able to hold a conversation with you. Chloe mentions to you that Tommy's going to start school next year, even though his preschool doesn't think he's ready. Chloe reports that staff describe him as being not as mature as his peers. She reports that she's concerned that he's still not talking as well as his friends, and demonstrates frustration with constantly repeating herself. So, on to next steps now. Again, of course, you're going to attend to Chloe's prenatal care, which was the reason for the appointment, and potentially provide some support for the family domestic violence. And you might look for an opportunity to provide some education to her on the impact of family domestic violence on her unborn child. After providing this care, again, I'd ask if there was an opportunity for you either to talk with Chloe during this appointment or to make another appointment to follow up around Tommy's ongoing communication skills. On this next occasion, you're going to follow up and ask about Tommy. You're going to follow up the previous hearing tests, the ENT referral, or the speech pathology referral that you suggested. Did they happen? What were the outcomes or the recommendations? And as a speech pathologist, I feel like I can speak for our profession and say that, sometimes a family won't be able to make one appointment or make 2 appointments in a row, and they get discharged from services. So we need to follow up with families like this and make sure they're re-referred and get back into the system. We'd suggest that you then again observe his current ear health and middle ear functioning. Have a look at his current communication and play skills and compare these to the expected milestones. Again, look at his global development across all domains. But also, we now have the added issue of his voice. And so pay attention and listen to his voice as he's been talking with you, and ask about the frequency of this reported laryngitis, and definitely do a structural assessment. Have a look in that mouth and see what's happening. As for management, we'd re-refer where indicated. So that might be for another hearing test. It might be for ENT for either hearing, but additionally now for his voice difficulties. Again, discuss your concerns with Chloe and re-refer him to speech pathology. And consider referral to paediatrician as indicated from your other findings, your other observations and assessments. And we're going to take a little sidestep here, and I want to talk to you a little bit about developmental language disorder, or DLD. DLD is the term for language difficulties that have a significant impact on a child's everyday social interactions and all their educational progress, and that are likely to persist. As Kate mentioned, it's considered an invisible condition because children with DLD look like every other child in a classroom or in a playground. DLD affects between 7 and 8% of children in Australia, or 1 or 2 in every school classroom. It's also a lifelong condition, and it has an impact on later social, academic and vocational outcomes, as well as quality of life, and reflect back to some of those stats that Kate introduced earlier in the talk. So while there's no cure for DLD, speech pathologists are able to provide evidence-based intervention which reduces the impact of DLD on activity and participation, and also to provide clients and their families with strategies to support their language skills. And language disorder, Todd, please. Thank you. Language disorder appears in the DSM-5 as follows. And no need to read this now, but just, it does appear there. And if you look at this, you will see the same language that I highlighted in the previous slide. We're looking for persistent difficulties that are significant and result in functional limitations. So for 3 really important features. So let's go back to Tommy now, and let's consider whether he may have DLD. If we look at persistence, Chloe reported to you that she first became concerned about Tommy's language when he was 2.5. So we have persistence. Functional impact. We have some information about his relationship with his mother, and we wonder about the impact of his language difficulties on his peers, particularly when the preschool are concerned about school readiness. In terms of significance, a speech pathologist can help ascertain this. And so we'd be looking for a speech pathologist who would assess his language at both the word and sentence level, but also at what we call a discourse level. So, for example, looking at his ability to relate a significant event, such as a birthday party or a family picnic. We'd also be looking for difficulties across many of those areas of language, both expressive and receptive, although these children often have no problems with their speech sounds, so often their speech is quite clear. Well, we can't make a diagnosis of DLD right now for Tommy without evidence of a significant language difficulty, but it does seem quite likely at this stage. And I'm going to pass you over to Kate now, who's going to talk about the next time that you see the family.
Thank you, Mary. So I guess moving into, say, a third episode of care with this family. And this time, Chloe has organised an appointment for Jessica, who we're yet to kind of meet in these little scenarios. So Jessica is now 8 years old. She has, as part of the consultation, Chloe mentions that Jessica's brother Tommy has now gone on to be diagnosed with developmental language disorder, and school have provided some referral information for Jessica, and it flags concerns about her academic progress. They also identify that she's quite quiet and shy, but very compliant, but they seem to be flagging that she has a very small social network. So if we have a look at our consultation here with Jessica, so in general, you note her engaging behaviour, her polite behaviour, but much like we saw previously when Tommy was younger, her conversation skills are really kind of centred around responding to your questions. And certainly when you start talking to her about her social networks, she describes feeling bullied at school. And what we're starting to see here is perhaps some queries about language disorder, but with a presentation that's very different to what we saw described from Tommy. And potentially we might be seeing more internalising behaviour associated with a language difficulty. And Mary and I really wanted to flag that this type of behaviour, the internalising behaviours, and associated with a shyer, more quiet behavioural presentation, is equally a common presentation of language disorder, as are those more externalising, outwardly observable behaviours that we saw with Tommy. And in fact, internalising behaviours associated with language disorder can often result in those children with language disorder really flying under the radar and not being identified, really having that hidden disorder. So from this consultation, we can start to see that these queried language difficulties could be impacting social relationships with peers. And the letter from the school highlights potential possible literacy difficulties under the umbrella term that academic progress has been slow. And it's not unusual for speech pathologists to be referred children around this age, the age of 8, because actually what happens here in the school curriculum is this differentiation in learning expectations, where those infant years of primary school have been focused on children learning to read, whereas as they progress into the upper years of primary school, there is an expectation that children are reading to learn. And consequently, the children who haven't made that transition with their literacy skills start to be identified as having larger learning concerns, or in this case, potentially a contributing language disorder. The case history helps us to identify that there is a family history of language disorder, with Tommy having since been diagnosed with DLD. And it's also important to note that the case history identifies that Jessica's mum was experiencing family and domestic violence while pregnant with Jessica. We saw that in that previous consultation. So it really guides us to needing to know what the research tells us about the relationship between complex trauma and communication disorders. Well, what it tells us is that overwhelmingly children who experience complex trauma in the early years of life are likely to have support needs relating to their communication skills. And we have this quote on the slide there from Snow, McLean and Federico. And that's Australian research that was published last year. And it describes the receptive and expressive language abilities and the reading comprehension skills of a sample of adolescents who were living in out-of-home care in Victoria. So all of those adolescents had experienced complex trauma in their childhood. And what the results showed was that 92% of that cohort of young people scored below the average range for their age on formal language assessment. And 100%, so every single one of the cohort, performed below average for their age on reading comprehension tasks. Furthermore, a meta-analysis that summated 40 years worth of research around the impacts of abuse and neglect in childhood and communication skills found that across studies, the language skills of children who are abused and or neglected are delayed compared to their peers. But really importantly, age matters. So the younger the child is when they experience abuse or neglect, the bigger the impact that has on their subsequent language skill development. And finally, we must acknowledge the increased risks of speech, language and communication needs for Aboriginal and Torres Strait Islander children, full stop, but then also Aboriginal and Torres Strait Islander children who've experienced complex trauma. So Australian research, the Small Talk Literature Review, uses the label a triple jeopardy in the context of child maltreatment and communication problems. And what they're identifying there is that Aboriginal and Torres Strait Islander children face these extra risks due to their disproportionate representation in the child protection out-of-home care systems, their increased risks of hearing problems, and broader societal and cultural barriers around recognition of aspects of Aboriginal language and cultural transmission. However, I also think we need to add into that mix the growing body of research we have that's helping us to understand the impacts of intergenerational trauma as well. So with all of this in mind, we can see that Jessica is a very high risk for language disorder, despite not presenting with behavioural difficulties. There is a family history of DLD, an in utero experience of family and domestic violence, the observations of her difficulties conversing with you in your consult, and the referral information that highlights both learning and social difficulties at school. And crucially, an additional and really important part of her assessment will include understanding her current home context and assessing whether ACEs and or complex trauma remain a current contributing factor for her. So I'm going to pass back to Mary now for, I guess, some final take-home messages from a speech pathology perspective, and then Sandra will be introducing the health pathway.
Thanks, Kate. So I guess our take-home messages from this evening's presentation are: you as GPs are in a really unique position to refer to speech pathology services. Families often come to you as a first point of call when they have a concern. So often we hear families say, "Oh, I spoke to the GP." So families do come to you early on. And we'd ask that when you either observe or a family share the challenges around behaviour management, that you consider whether poor communication might be contributing to the behaviour. Perhaps the child's unable to express themselves, or perhaps they're not understanding what's required of them. We'd also ask that if a family share that they or their child has learning difficulties, or perhaps that they're struggling at school, that you consider whether language skills might be impacting on their performance in the classroom. And finally, that you always consider referral to speech pathology in the context of family and domestic violence and or high ACEs, given the information and really hard-hitting evidence that Kate's presented to us this evening. Now we have on the next slides, we have a few references for you, which Todd might flick through for us. So we have a few references for you. Could you keep flicking to the last slide, Todd, please? Maybe. Here we go. And on this last slide, we've just included for you a few websites. The Raddled website on the left is a UK-based website, and the CELDA website on the right is an Australian website. Now, both of those websites have lots and lots of current information around language difficulties, as well as developmental language disorder. And there's all sorts of material that's relevant for both you as well as your patients or the clients that you see. So there's videos, there's videos of people talking, there's mini lectures, etc. So there's a wealth of resources if you want to have a look at those. And I'm going to pass over to Sandra now, who's going to introduce the referral pathway to you.
Thank you so much, Mary, and thank you so much, Kate. They were fantastic presentations, and it's been a real delight to work on this pathway with you. And I would also like to acknowledge Chantel Edlington, who also provided a lot of insight into this pathway from Speech Pathology Australia. Can I please confirm that you can see the PowerPoint now as you're supposed to see it? Are we all good to go? I can't hear anything, but I'll assume that's a yes unless someone jumps in. So thank you. My name is Sandra Fitzgerald. I'm one of the clinical editors with Community Health Pathways, and I'm just going to give you a brief introduction to health pathways in case some of you aren't familiar. Apologies to those of you who are incredibly familiar with health pathways and who may have heard me give this before. But just a very brief introduction. Health Pathways is based on a highly successful model of collaboration that was developed in New Zealand in this area around Christchurch on the South Island. And it's been around since 2006, and Hunter New England were the first ones to bring it over the ditch in 2012 and Central Coast in 2013. And for those of you who've not used the platform before, at first sight, Health Pathways just looks like any other set of online guidelines for the assessment, treatment, management and referral of clinical conditions with a robust set of accompanying referral pages. And that's in fact what I will be showing you today. But the main difference is that at its core, Health Pathways has provided our health system with a way of working together to best manage our collective patients and effectively implement system change. And so this pathway I'm showing you today is a little bit of a taste of that, where we did have a speech and language pathway in preschool children, but it wasn't, it needed a little bit of work to tidy it up, and it really hadn't incorporated all those elements around trauma and DLD that we've heard about tonight. So with the great help of Kate and Mary and Chantel, that's been included now, and I think it's a more robust pathway, and it went live this morning, so you are one of the first people to have a look at it. And so just so you know, when we're developing individual pathways or sets of pathways, the process we've adopted allows clinicians across the primary and acute sectors to develop relationships, openly discuss issues, strategise solutions, and that way make the best use of specialised care and scarce resources, and also to innovate change to improve access to care. So Health Pathways then becomes the key system enabler that allows Hunter New England Health to evolve and adapt rapidly, and the online portal that I'm going to show you tonight becomes the communication channel and repository of that information for clinicians. So on your screen now, on the left-hand side of your screen, you'll see top left the login details for Hunter New England Health Pathways, and that is password protected for clinicians only. But underneath that, you'll see the patient info login, which is not password protected, and that's a URL you are absolutely welcome to give to patients. All the information you'll find on there has been vetted by our clinical editing team and also by our patient info team to be in line with the clinical information on the pathway, and also at a suitable readability level for the general population. And those same details on the right are for the Central Coast. Now, this pathway that I'm just about to show you only went live in Hunter New England today, and it will be coming to the Central Coast very soon. So hopefully you can now see the Health Pathways front page. And if there's two ways to find pathways, you can either go down the table of contents to find what you're looking for, or you can just pop it up in the search bar at the top. So I'm just going to pop it in the speech bar. It's the search bar, and there you can see speech, language, and communication difficulties in children. And that's the pathway that Mary and Kate have been very elegantly and eloquently spruiking tonight. Our pathways are all set out the same way. If you see these icons at the top, it means it's got some Aboriginal and Torres Strait Islander information, or it might have some multicultural information and related pathways at the top. A little bit of background, and then assessment, management, and referral. But I'll just show you some of the key features here. Under background, in the About box, we've got all that information that Kate started the presentation with, just some background information that's really good to know when you're working in this space. In the assessment section, we've got all of those things around, you know, what the indicators of concern were that they talk about, what sort of history you're wanting to ask about, and then, you know, looking specifically around things like speech sounds, evidence of stuttering, abnormal sounding voice, and pragmatic difficulties. And then they also did talk about the developmental milestones, and in here you've got all the primary and secondary screening tools, and specific screening tools for specific conditions, and so on. And then just around performing an examination, as I said, have a good look around in the mouth and so on. And then management, a lot of the management here is referring off, particularly off to the speech pathology. But we've got a really great audiology referral page. So, and all our referral pages are divided up across the district, and you'll usually see that that is then further divided into private and public. And then our speech pathology page, I'm hoping has just been updated and reviewed today, reviewed and updated today, and hopefully that's gone live, because we had noticed that there was a few errors in there. But you will find all the private speech pathologists in your area, as well as how to refer into the public system. And then at the bottom of every pathway, we have got some further information for those people who want to know more about it. And in the health professionals, we've got some further information. For patients, we've got the things that you might like to give to your patients, and this is the section that is then replicated on our patient info site. And then, oh, where did all our sources go? Here we are, sources. And there's the select biography that's got some of those references that I think that Kate and Mary might have shown there. So we always love feedback on our pages. So if you've got anything you'd like to share about this pathway, something you think that's missing or something that you don't think is quite clear enough, or anything that you'd like to tell us, you can just click on the send feedback button and tell us your thoughts, and we will get back to you usually within a couple of business days. And anytime you want to navigate to the patient info site, just click on the blue bar at the top. That'll get you to the home page, and then you can hop over to the patient info site. So I will stop talking now in case there are some questions that need to be answered. I'll throw back to you, Todd. Well, I should probably stop sharing to do that, shouldn't I?
Thank you, everyone, for presenting. Kate and Mary, I thought your presentations were great, as Sandra said, and Sandra, thank you always for your expertise.
Pleasure.
We actually don't have any questions tonight, so that might mean that you've covered everything that everyone needed to know. Just, I do ask if everyone could please go and fill out the evaluation, especially for those GPs who would like their points uploaded. And if you would like a certificate of attendance, please fill out the evaluation. I think we might just leave it there for now. I do just want to also mention that we have a second event following on from this one, which is going to be on, Kate, have you got the address handy?
No, I didn't bring the dates in with me.
I
feel like it's Tuesday week.
Tuesday the 9th of November, I'm pretty sure.
That's exactly right. That is right, and it's at 6:30, and it's going to be more of a online panel discussion. It'll be via Microsoft Teams, so I think it will be fantastic. So please come and join for that second session on the 9th of November. We do have a question that's just come in. Can you go through exclusion for referral for permanent issues?
I don't feel really clear on what that question's referring to. I'm not sure if that listener can provide a bit more information.
I'm just going to wait a few minutes because she might type something else in.
Yeah. And I guess on that point, just trying to predict a little what that person might be talking about, what I would say is that speech pathologists have a role to play with children across all severities of communication disorders. So we certainly don't talk to exclusionary referral pathways, rather inclusionary. Wherever there is an identified communication support need, from mild through to profound, we would hope that that young person could be connected with a speech pathologist.
All right, thank you. Nothing else has come through, so hopefully that person might come on the 9th and can discuss it with you online directly, which will be great. All right, I think that's all we need to say for tonight. So thank you all very much. And Todd, thank you for your expertise in the background.
Thank you.
Thanks.